Good afternoon, everyone. So you have your exams coming up. Probably next Saturday, I'll not take a full class. I'll just come say hi and go. Today I'm starting liver. Before we starting liver, you should understand liver is one of the most important topic, both theoretical point of view, surgical point of view. The same part is again helpful for you even in general medicine. Regarding some of the bits here, there are so many questions in the entrance that liver carries. So you need to be a bit more focused on liver. And liver has got many diseases that are useful for you in real life too. You come across so many other things because liver is the most common organ of secondaries. So it is important. Now let us start with liver. Liver is, as you all know, it is the largest organ in the body. Largest organ in the body. So it has basically how many lobes? 8 lobes, that is according to the conide segments. Otherwise there are 2 lobes, right lobe and left lobe. How does it develop? It develops from the foregut, develops as a bud. Okay, it develops as a bud and that bud grows and 2 of them fuse, right hepatic and left hepatic lobe, they both fuse and they derive blood supply from the celiac plexus because foregut artery is celiac plexus and it derives blood supply from there. Now you should know what are the surfaces a liver has. The liver has an anterior surface, a posterior surface, and the posterior surface is also called as bare area of the liver. It has got a right surface, it has got a superior surface, and it has got a inferior surface. Left hepatic duct, you have to remember, is the largest amongst the two, right and left, and it extends outside the course, outside the liver course. It is about 2 centimeter. It is 2 centimeters in length, so it will become for us imperative for operating on the left hepatic duct. So 2 centimeters is outside and is accessible, and it is accessible for us. And you should remember one more thing in the anatomy of liver: porta hepatis and its relation. What is porta hepatis? Porta hepatis is nothing but it is the posterior portal vein, it is the hepatic artery and the hepatic ducts. And the hepatic ducts, and it is posterior portal vein. Portal vein is posterior. Hepatic artery is left and hepatic ducts are right. Hepatic duct are right. So you should know from behind forwards, from behind forwards how it comes. First thing is portal vein, then hepatic artery, followed by hepatic duct. Behind forwards, from behind forwards. It's been number of times asked. They ask it directly from behind forwards. So first is portal vein, then hepatic artery, then the hepatic duct, then the hepatic duct. Then there is regarding the arterial supply, hepatic arteries, right hepatic artery, left hepatic artery, both the branches of the celiac plexus or the celiac trunk. And then what are the specialities of this hepatic ducts? There is a very conspicuous or dangerous right hepatic artery that is aberrant. Aberrant right hepatic artery. What happens here? It arises from the superior mesenteric artery and runs posterior to the pancreatic head. So whenever you're performing pancreatic head surgeries, you have to be careful. Otherwise, you may injure this and that will cause damage to the liver. So we should be very, very, very careful. Then there is an accessory or replaced left hepatic artery that arises from the left gastric artery. It arises from the left gastric artery. And what is this called as? It is either called an accessory left hepatic artery or a replaced hepatic artery. Is a replaced hepatic artery. Then there is actually an accessory cystic artery. Okay, it originates from the gastroduodenal artery, or sometimes it also can originate from the common hepatic artery. Okay, common hepatic artery. So when you are dealing with the anatomy and its relations nearby, you should remember an aberrant right hepatic artery arising from the superior mesenteric artery. Okay, and it runs just posterior to the pancreatic head. Or there is a replaced on an accessory left hepatic artery which will arise from the left gastric artery. Then there is an accessory cystic artery that originates with the gastroduodenal or artery. Sometimes it can arise from common hepatic artery. Sometimes it can arise from common hepatic artery. So from behind forwards, portal vein, hepatic artery and hepatic duct in the porta hepatis. Posterior, right, and then posterior, left and right. Left hepatic artery, right hepatic duct and posterior portal vein. This is what you should remember. Then the surgical anatomy of liver is very, very, very important. And how does the surgical anatomy take place? The surgical anatomy, you will draw an imaginary line that is called as Cantonese line, Cantel's line. It is called as Cantel's line. Or you can call it as cholecystocable line. It is an imaginary line running from gallbladder fossa to right side of the inferior vena cava. To the right side of the inferior vena cava. Imaginary line running from gallbladder fossa to right side of IVC. That is IVC is inferior vena cava. Then this imaginary line divides the liver into two halves. Okay, two halves, and these two halves are right lobe of the liver that contains 5, 6, 7 and 8 segments. Okay, 5 immediately at the portal vein, 5, 6. Okay, 5, 6, 7, 8. 5, 6, 7, 8. Okay, that is divided. And then you have the left one. It starts just like 5 starts. 1. Okay, it starts just like that. That is 1, 2, 3, 4. So 1, 2, 3, 4. Is it understood? 1 is behind. Okay, where 8 ends, 1 starts. 8 ends, 1 starts. 1 just beside it is 2, 3 and 4. 4 is again divided into 4A, 4B. 4A, 4B. Then there is segments to the left of the falciform ligament. Falciform segment, it is known as second. Then there is something called as caudate lobe, and this is segment 1. This is in segment 1. So left side is 1, 2, 3, 4, right side is 5, 6, 7, 8. So where 8 ends, 1 starts. So 1, 2, 3, 4A, 4B, 5, 6, 7, 8. Caudate lobe is in segment 1. Then there is something called as a Riedel's lobe. Something called as a Riedel's lobe. It is a tongue-like extension. Please remember, it's a tongue-like extension from the right lobe inferiorly. Tongue-like extension from the right lobe inferiorly. Then there is something called as segments to the left of falciform segment. Okay, segments that are present in the left side of the falciform segment are segment 2 and 3. Segment 2 and 3. Caudate lobe is the lobe that is not affected in Budd-Chiari syndrome nor in cirrhosis of liver. nor even in cirrhosis of liver. This lobe does not get affected both in Budd-Chiari syndrome or cirrhosis of liver because it takes its drainage directly from inferior vena cava. Inferior vena cava. So it's basically resistant to both portal hypertension, that is cirrhosis of the liver, as well as Budd-Chiari syndrome. Then there is something called as the fourth lobe. As I said, it's got two segments, that is A and B. A and B. When A and B, these segments are called, this is called as a quadrate lobe. Fourth lobe, quadrate lobe, quadrangular, quadrate lobe. Fourth lobe is also called as quadrate lobe. Why these conoid segments of the liver are important? They are important because based on that, we do hepatectomies. Okay, then there are named hepatectomies. One is on conoid naming. Okay, conoid segments, conoid naming. When we do removal of lobe number 2, lobe number 3 and lobe number 4. It's called as left hepatectomy. It's called as left hepatectomy. When you do a 2, 3, 4, then you remove 2, 3, 4 segments, it is called as left hepatectomy. Then there is a removal of the segments from 5 to 8. 5, 6, 7, 8. 5, 6, 7, 8. 5, 6, 7, 8. It is called as right hepatectomy. It's called as right hepatectomy. When you extend 5, 6, 7, 8 to 4, okay, when you also remove the quadrate lobe, when you extend, it is called as extended right hepatectomy. Extended right hepatectomy. When you remove segments 2, 3, 4, okay, along with 5 and 8, segments 5 and 8, therefore AB. Here it is 5 and 8, then it is called as extended left hepatectomy. Extended left hepatectomy. This is about conoid hepatectomies based on conoid segments. Then there is something called as Brisbane 2000. Okay, Brisbane 2000, it has changed the names of hepatectomies. You can remember because entrance point of view. Not in your theory you should not write because they will not ask you about Brisbane 2000. They will ask you about conoid segments. So the upper one, the first one I said is for conoid segments that you should write in the exam. Okay, surgical anatomy of the liver is a 4-mark question, regularly asked. So you have to remember and write. But the Brisbane classification is different. This is more for entrance point of view. Right hepatectomy is 5 to segment 8, 5, 6, 7, 8. When you remove its right hepatectomy, then there is something called as right trisectionectomy. Right trisectionectomy. This right trisectionectomy is nothing but extended right hepatectomy, where you remove segment 4 in extended right hepatectomy of the conoid naming. Left hepatectomy is 2 to 4, 2, 3, 4. Left trisectionectomy is extended left hepatectomy plus removal of segments 5 and 8. 5 and 8. In Brisbane 2000, there is also another small classification that comes into play, that is left lateral hepatectomy. That is when you remove lobes number 2 and 3 only. Left lateral hepatectomy, when you only remove segments 2 and 3. When you only remove sections 2 and 3. Then lobule of the SNS of the liver. This is very, very, very important. Why? Because based on these zones, 3 zones, is what you will decide the injury to the liver, infarction to the liver. Okay, basically central hepatic venule and peripheral terminal portal triodes contain portal vein, hepatic artery and bile duct. That is porta hepatis. Okay, what happens? There are 3 zones. Okay, one is a peripheral zone, then there is an intermediate zone, that is zone 2. Zone 1 is the peripheral zone, zone 2 is the intermediate zone, and zone 3 is perivenular zone. Perivenular zone. Okay, there is interlobular connective tissue in this lobular acinus. Then there is a central vein then there is an hepatic cord, hepatocyte cord, and the portal triad. Portal triad, zone 1, 2, 3. Zone 1 is the peripheral zone, which is rich in nutrients and oxygen, so the maximum amount of blood supply goes there. Then there is a central zone, or the intermediate zone, zone number 2, not really so important. Then there is zone 3, that is zone 3, which is most prone, or perivenular zone, which is most prone for hypoxia. This has been asked number of times, which is more prone for hypoxia. Centrilobular necrosis, common in hypotension. There is a centrilobular necrosis when there is hypotension, affects the zone 3, affects the zone 3. That is the reason when you have multi-organ dysfunction, liver starts failing in shock, and the patient will have jaundice. Which area of that venue or lobule of acinus of the liver is getting affected? It is the peripheral zone, or perivenular zone. Periportal, maximum blood supply, so rich in food and oxygen. Centrilobular, then nothing much, we don't have to worry, that is intermediate zone. And then there is perivenular zone, which is most prone for hypoxia. Centrilobular necrosis is common in hypotension, that is in shock, that affects the zone number 3 predominantly, and this zone number 3 is called as perivenular zone, or zone number 3. Then proper hepatic sinusoidal blood flow. This is important. Why? Because the blood supply of the liver. Endothelium lining of the hepatic sinusoids is the most important functional unit of the liver. What is that? The endothelium of the hepatic, the endothelial lining of the hepatic sinusoids is the most important functional unit of a liver. Sinusoids are flooded with blood from portal vein and hepatic artery, and it is always unidirectional flow, and it's always unidirectional flow, and the direction of the flow is towards the hepatic venule, it is only unidirectional flow. Low resistance and low pressure system, it is only about 2 to 4 millimeters of mercury in the sinusoids. Sinusoidal epithelial cells are separated from the hepatocytes. Okay, sinusoidal epithelial cells are separated from the hepatocytes via the space of Deci. What are they getting separated? The sinusoidal epithelial cells are getting separated from the hepatocytes, liver proper, by a space, and this space is called as space of Deci. Then there is something called as Kupffer cells. This is nothing but it is a brother or sister, whatever you call, analog of your macrophage monocytes. So macrophages, they are Kupffer cells are brothers or sisters, what you call analogs of macrophages in your blood. So macrophage monocyte system of the liver, and these are present in the sinusoids. Okay, the most important functional unit of this liver is nothing but hepatic stellate cells, ITO cells. They are also called as ITO cells, and these are the things that are present in the space of Deci. These are the cells that are present in the space of Deci. What do? They synthesize extracellular collagen. And seen in they store vitamin A. And they have a central role in fibrosis, that is at the conversion of cirrhosis. ITO cells play an important role in your normal liver becoming cirrhosed. So what do? They have extracellular collagen. They synthesize extracellular collagen. They store vitamin A, and these are the most prominent, or the prominent role these ITO cells play in conversion to liver cirrhosis. In conversion to liver cirrhosis. And in anatomy, there is something called as canals of Hering. Canals of Hering. Hepatic stellate cells, that is ITO cells, are seen in space of Dissay, as I told you. And these, they have canals of Hering. They have bile canaliculi. Okay, bile canaliculi. They form a ring. Okay, they form a ring around the hepatocytes, around the liver cell, that is hepatocyte. They form a ring that drains into the canals, and that drains into the canals, and all the system drains into the canal, and these canals are called canals of Hering, which further drain into the bile canaliculi, which further drain. The hepatocyte drains into these canals of Hering, and these canals of Hering, as they are canals, they connect the bile canaliculi, and that bile goes into the bile canaliculi, and from there on they enter the bile duct. Now then we come to the blood supply of the liver. The maximum amount of blood to the liver goes to the portal vein, that is about 75% in total entrance bed. Hepatic artery gives blood supply to the liver only by 25% entrance bed. But 50 to 60% of oxygenated blood comes from the hepatic artery. 50 to 60% of the oxygenated blood to the liver goes via the portal vein. 25% of the cardiac output flows through the liver. 25% of the cardiac flow, that is almost 1/4 of the whole blood that your cardiac output generated goes to the liver. It decreases in exercise and increases when the food is getting digested. Decreases when you're exercising, and increases when the food is getting digested. Hepatic artery pressure is similar to the systemic pressure. Is same as the systemic pressure, 120, 80, 110, 70. Whereas the portal vein pressure is quite low. It is 6 to 10. It is 6 to 10 millimeters of mercury. And I already told you about the sinusoidal blood pressure. It is about 2 to 4 millimeters of mercury. 2 to 4 millimeters of mercury. So your hepatic artery blood pressure is normal to the systemic blood pressure. The portal vein is 6 to 10 millimeters of mercury. Anything 10 is considered as abnormal, and anything about 12 millimeters of mercury is considered as portal hypertension. And sinusoidal, that is sinusoidal pressure, is about 2 to 4 millimeters of mercury. 2 to 4 millimeters of mercury. And then we are moving to something called as the most important aspect of grading systems in the liver. And one of the most important grading system that we use is Child-Pugh score. When I will be talking about this, but I want to explain it before, because in both acute liver failure and the chronic liver failure, that is cirrhosis of the liver, this is important. So we will be grading the liver failure based on a system called as Child-Pugh score. Child-Pugh score is important if you want a patient to undergo liver transplant. If you want a patient to undergo liver transplant. So basically there are three parts in a Child-Pugh score, and each is given 1 point, 2 points and 3 points. Okay, and there are about 5 different aspects that we will be checking in liver failure. That is encephalopathy, ascites, bilirubin, serum albumin, and prothrombin time. Encephalopathy, ascites, bilirubin, albumin, prothrombin time. These are the 5 headings then where we see in Child-Pugh score. In Child-Pugh score, what do we see? We see 5 headings, that is encephalopathy, ascites, bilirubin, albumin, and prothrombin time. Now, each is given 1 point, 2 point, and 3 points. Okay, each is given 1 point, 2 point, and 3 points. 1, 2, 3, Child-Pugh score 1, Child-Pugh score 2, and Child-Pugh score 3. When do you consider Child-Pugh score 1? When encephalopathy is absent. Okay, when encephalopathy is absent, when there is no ascites whatsoever. Bilirubin should be anywhere between 1 to 2 millimeters of mercury. Bilirubin should be anywhere between 1 to 2 millimeters of mercury, and serum albumin should be greater than 3.5 gram per deciliter. 3.5 gram per deciliter. Bilirubin should be 1 to 2 milligrams per deciliter, whereas in albumin you should have greater than 3.5 gram per deciliter. Prothrombin time should be anywhere between 1 to 4, and it should be anywhere between 1 to 4. And then the 2, when do you consider Child-Pugh score as 2? When you have encephalopathy grade 1 or grade 2, grade 1 or grade 2, when there is mild ascites, when there is bilirubin is 2.1 to 3 millimeters of mercury, 2.1 to 3 millimeters of mercury, milligram per deciliter. Albumin about 2.8 to 3.4 gram per deciliter, 3.4 to 2.8 to 3.4 gram per deciliter. Prothrombin time should be anywhere between 4.1 to 6, 4.1 to 6, 4.1 to 6, 4.1 to 6. That is Child-Pugh score 2. Then there is Child-Pugh score 3, wherein you have encephalopathy of grade 3 and 4. Ascites is moderate, greater than 3.1 milligram per deciliter of bilirubin, and serum albumin being less than 2.7 gram per deciliter, and prothrombin time greater than 6. How do you grade them? Grade A is 5 to 6 points, grade B is 7 to 9 points, and greater than 10 to 15 points is grade C. Grade 1, 1 to 6 points, 5 to 6 points, grade 2 is 7 to 9 points, and grade C is 10 to 15 points. 10 to 15 points. 5, 6, 7, 9, and 10 to 15, grade 3. Then there is something called as MELD score. This MELD score is based on your CBI. You should remember it as CBI. C stands for creatinine, B stands for bilirubin, and I stands for INR. INR is nothing but International Standardized Ratio for your prothrombin time, INR. INR is nothing but CBI. MELD score is nothing but MELD score is CBI. C stands for creatinine, B stands for bilirubin, and INR. I stands for INR. Recently, waiting list for liver transplant is based on, waiting list for liver transplant is based on this MELD score. Initially, MELD score was used to predict mortality when we do something called as TIPS. TIPS I'll be talking about in the later class. TIPS is nothing but transhepatic transhepatic internal jugular portosystemic shunt stent. TIPS is that. So previously we used to check for mortality based on this MELD score. Now we are doing it for giving earlier liver transplant. Values vary from 6 to 40. Liver transplant is allowed only for MELD score greater than 15. Anything above 15 score, then only we go for liver transplant. Similarly, for pediatric, there is something called as PELD score. That is modified end stage liver disease scoring. And here it is PELD. PELD is nothing but pediatric end stage liver score. How do you check in this? Bilirubin, albumin, nutritional status, INR, and age. Okay, what is PELD score? PELD score has bilirubin, albumin, nutritional status, INR, and age. There is CBI, and it is Bania is nothing but a trader. In Hindi, Bania is nothing but trader. BANIA. It is about PELD score. PELD score's components are bilirubin, then albumin, nutritional status, INR, and the age. Okay, then you should remember certain important points based on certain important points in liver investigations. So I'll tell you in liver function test there are some points that you should remember. ALT, AST are elevated in liver disease. ALT and AST are elevated in liver disease, and ALT is liver specific. ALT is liver specific. AST is elevated in diseases of heart, kidney as well as the muscles. So ALT, alanine transaminase, is the thing that you have to check for liver disease. Alkaline phosphatase is elevated in obstruction of biliary system. Obstruction of biliary system. Talking. Okay. Obstruction in the biliary system due to excessive production. GGT is increased in alcohol-related liver disease. GGT, glutamine gamma transferase, is elevated in alcohol-related liver disease. Hypoalbuminemia is a marker for chronic liver disease. Hypoalbuminemia is marker for these are all liver functions. Okay, LFTs. What are the points of LFTs? I'm telling you. GGT is increased in alcohol-related. Hypoalbuminemia is marker for chronic liver disease. PTINR is the marker for advanced chronic liver disease. PTINR is the marker for advanced chronic liver disease. Then there is MEGXC, that is nothing but monoethyl glycerinixylidine. Okay, monoethyl glycerinixylidine is helpful in assessing the prognosis of a transplanted liver. Assessing of the prognosis of liver transplant. Then there is something called as indocyanine green clearance. Clearance, it has got prognostic ability to assess the liver. Okay, prognostic level to be assessed in a cirrhotic liver disease. Liver parenchyma is made up of two types of cells. One is hepatocytes, which perform excretory and synthetic functions, and Kupffer cells. They have function of reticuloendothelial system. It is macrophages, monocytes of your blood. Both of these can be investigated with radionuclide scan. Both of these things will be checked. There are two types of radionuclide scans that we usually do. One is a HIDA scan and then a sulfur colloid scan. HIDA scan is based on the functioning of the hepatocytes, and sulfur colloid is based on the functioning of the Kupffer cells or the reticuloendothelium system. Then how does this HIDA scan work? It works as IDA compound are taken up by the functioning hepatocytes. Okay, they are taken up by the functioning hepatocytes, excreted unchanged in the bile ducts, unexchanged in the bile ducts and the gallbladder. When they are exchanged or excreted directly as the same. What are the uses of it? Its clinical uses are: it assesses the regional liver function. Bile leaks in liver trauma, investigation of biliary obstruction. It is useful where? It is useful in investigation of a biliary obstruction. Then it is useful in choledochal cyst. It is also used in acute cholecystitis. In fact, in acute cholecystitis, HIDA scan is gold standard investigation of choice. And then it will also help us differentiate hepatocellular tumor. hepatocellular tumor. Why? Because HCC will not take up colloid or HIDA scan. It won't take up HIDA or colloid scan. HIDA or colloid scan. Then there is sulfur colloid scan. This is based on the functioning of the reticuloendothelial system or the Kupffer cells of the liver. Hotspots, Mars lesions which contain functioning RES, that is Kupffer cells. Non-functioning areas, Mars lesions which do not contain any Kupffer cells. Clinical uses, FNH, that is folliculonodular hypoplasia, only tumor which consistently contains functional reticuloendothelial system cells and therefore shows uptake and the colloids, uptake of the colloids. FNH tumor only, XFNH tumor only. Hepatic adenoma, non-functioning Kupffer cells, hence do not uptake. Then hence they do not uptake. Hence they do not uptake. Acute liver failure. Acute liver failure. Shall we start with acute liver failure or we'll go for the next class? It's already 2:41. I was a little late to the class. We'll continue in the next class. Acute liver failure. Nothing. But you should know what are the signs of liver failure. Liver flap, drowsiness and coma. Liver flap, drowsiness and coma. What are the etiological factors for liver failure? Hepatitis A, B, C, D, E. Paracetamol poisoning, mushroom poisoning, shock in multi-organ system. What did I say? DCAS. Budd-Chiari syndrome, Wilson disease, fat liver of pregnancy, drug reactions like halothane and antidepressants. These are the things that are useful. These are things that cause hepatic failure, acute liver failure. So we will discuss about acute liver failure, portal hypertension, the chronic liver disease in the next class, and after which we will continue further. Anybody has any questions? Anyone has got any questions? So our toppers and know everything, is it? Okay.